Good morning, good afternoon, and welcome to this webinar on making the best of FLS, key performance indicators. I'm Dominique Pierrot, Science Manager at IOF. Today, we have the great pleasure to welcome two speakers, Professor Kassim Javed from Oxford and Professor Serge Ferrari from Geneva. Before giving the mic to them, I just would like to inform you that attendees are automatically muted. And I also would like to encourage you to ask questions during the webinar by typing them into the question box of the GoToWebinar control panel. This being said, I'm happy to give the mic to our two speakers of the day.
Thank you very much, Dominique, and it's a warm welcome to everyone to this webinar on key performance indicators for FLS, especially during these challenging times. We're very grateful for your attendance, and I can see we've hit 100, so I'm very glad that Serge is not going to walk away now. My name is Kassim Javed. I'm an academic rheumatologist and associate professor of metabolic bone disease at the University of Oxford, and I'm really privileged to have Serge Ferrari. Serge, would you like to introduce yourself to those of you who may, those of us who may not know you?
Thank you, Kassim. Hello, everyone. Serge Ferrari from his office in Geneva. I am the head of the service and laboratory of bone disease here, and I'm delighted to collaborate with Kassim Javed today to talk to you about the new questionnaires that has been developed for the KPIs.
Should we start off with some questions, Serge?
Yes, good idea. So to warm everybody up, would like to ask you a couple of questions just to get a better idea of your experience with FLS and the IOF. So Dominique, could you please send the first question? So here it is. Do you have a fracture liaison service in your hospital? Please press yes or no in the next 10 seconds. And we are waiting for the results to appear on the screen. Here we go. Okay, so it's half and half. So it's excellent because we're gonna teach more to those who know and teach even more to those who don't yet know about FLS. So our second question, I guess, relates to the 50% that has voted as having an FLS. So for those who have an FLS, is your FLS on the best practice map of the Capture the Fracture website from the IOF, which means do you have any sort of star for your FLS from our program? Please say yes or no, and we'll vote for 10 seconds.
These are long 10 seconds, Serge, aren't they?
It's time flies, it's coming. And now we should get the answer to this question. And it's 2/3 with FLSs are on the CTF program and a third doesn't. So we hope that after this presentation, those who have not yet requested to be reviewed and starred by the Capture the Fracture will do so. So let me start by reminding you that we currently have 427 fracture liaison services mapped on the IOF Capture the Fracture website. Those are all the FLSs around the world, 46 countries, 6 continents that have been reviewed by our expert at the IOF and have received a star to grade the quality of the liaison service. And I assure there are many more that are currently under review. So for those who are not familiar with the procedure, I remind you that the first step is to submit your application to be reviewed that you find on the IOF website. And then at that time, you'll be marked in green on the worldwide map. And then it goes through a process of review internally that goes through a questionnaire that we call the best practice framework. And according to the best practice framework, your FLS will then be graded. Next slide. So what BPF is really a set of 13 criteria that cover all the structural aspects of a fracture liaison service. It sets the standard for an FLS, and here are the 13 criteria and standards. They go from the process you use to identify patients, to evaluate patients, to assess the time post-fracture, etc., etc. And for each one of those criteria, like shown on the right of the slide, for example, for the question of how your FLS identifies patients, there are 3 levels by which it can be graded. The bronze medal level is if you already have a system in place to identify patients, even if they are not tracked. You get to silver if they are tracked, and you get to gold if in addition they are independently reviewed. And so with those 3 levels with 13 criteria, putting them together, you get a score. And the scoring reflects the 5 domains that define the quality of a fracture liaison service regarding to capturing patients with hip fractures, ordering patients with other types of fractures, outpatients with fractures, vertebral fractures, and then also the level of organization that you have, particularly regarding to falls assessment and keeping a database. So an FLS should be effective at the organizational level to start with, and that is what the Capture the Fracture website and evaluation is made for. Next one. Now, once you have an FLS in place, it's equally important to remember that monitoring the performance of that fracture liaison service is also part of the job. Initiating a system to identify and capture and investigate patients with fractures, to initiate therapy is of course necessary, but then you need to know where that leads you, and you need to monitor the efficacy of the system. Next slide, please. Now, not every FLS is automatically effective, and it should actually have a triple aim: to be effective, to be efficient, and to deliver a patient experience, possibly a favorable one. That being said, next slide, please. The FLS, as I explained, should be effective at the organizational level, and that is what we evaluate currently by the best practice framework. But for the patient perspective, you also need to know if your FLS is effective at the patient level. And for that, we have developed a set of KPIs, key performance indicators, which indicate at the patient level the current performance for the key steps in your FLS, prioritize what to improve, and help you to understand how to improve the quality of the service that you are delivering. And now Professor Jabaid will lead you through those KPIs one by one. But first, I'd like to challenge him, and I would like to ask him this. The obvious key performance indicator for a fracture liaison service is to prevent fracture, isn't it? So just measuring refracture rates in a given FLS should be sufficient to know if you're delivering good service to the patients. Cass, is it as simple as that, or do we need to do more?
Thank you, Serge. I think in some senses it's as simple as that. For decision makers, that I agree, that's all they're really focused on, is the clinical and patient outcome. But these indicators are really built to get your FLS to be more effective. And actually, refracture rates are a pretty bad way of telling if your FLS is working well. And that's because of a number of factors. We don't know what the expected fracture rate is for an FLS. So if you observe a refracture rate of, say, 5%, should it have been 6%, 9%, or 20%? And these variables, such as age, comorbidities, and even which patients are going to which hospitals, means capturing fractures is very difficult. We know from a lot of studies now that if patients are put on treatments promptly and stay on treatments, then the drugs work. The fracture rates will go down. And the key focus for the performance indicators is making sure when you put the FLSs into whatever system, a community system, a hospital system, a regional, or even a national system, the FLS is delivering at each of those key steps from identification to monitoring to get you to that goal of making sure as many high-risk patients are on treatment for as long as possible.
Very good, Cass. So can you lead us through those KPIs that have been now developed for that purpose?
For sure. Thank you, Serge. So I'm going to summarize how the KPIs work. I think the why the KPIs work is because we recognize, as Serge said, not every FLS is effective. And we need to start measuring what we're doing so we can then deliver on the expectations that many of our decision makers and policy makers have invested in setting up FLSs around the world. And then we'll finish off with what is the next step. So an FLS seems quite simple. Just find a patient who's had a fracture, assess them however you want to, and then just get them on treatment. But it's a very complicated pathway, and that's because it crosses many clinical domains. People come in through the emergency room, then they go to the orthopedic department maybe, then they might go to an internal medicine or metabolic bone, and then they go to primary care or community settings. And it's making sure that we track the patient through these different settings to make sure we identify enough, they all get tested and assessed for fracture risk. We recommend appropriate treatment based on their risk, and as Serge mentioned earlier, we get them monitored. And it's a chain, it's a link. If any of those links are weak, then we won't deliver on the lower refracture rate, fewer secondary care admissions, and then those healthcare savings that we've promised our decision makers the FLS will deliver. And this is the real heart of the KPIs. So we took some KPIs that were all developed in the UK and working with the IOF Capture the Fracture CSA, that Serge and I co-chair, as well as inputs from the FFN, from Robin Spearin from the FFN, and then from Andrea from the NOF in the USA. We've mapped the pathway of the patient and actually shown from identification, investigation, treatment recommendation, all the way to adherence, what are the key steps that an FLS needs to check off on their checklist to make sure they're working well. So I'll kick off with the KPIs, and then Serge has got a question, then we'll go to the next one. And at the end of the presentation, we're more than happy to take additional questions. Just post them on the GoToWebinar app. So the first one is pretty basic. Are you finding enough non-spine fractures? We put spine fractures in a separate KPI because they are slightly different. And this is the first step. The FLS has to find as many patients who fracture over the age of 50 after a fall from standing height or less as possible. The challenge is, what's the target? What's the expected caseload? And we can get this sometimes from local audit data. So if you're very good hospital administrative system where you're sure that every fracture gets logged, you could use this as your denominator or the expected local caseload. You can use epidemiological studies to say in this population with this age and sex distribution, this is the expected number of fractures. But a very crude and simple but surprisingly effective rule of thumb is if you know how many hip fractures you have, then you times that by 5. That's roughly the number of fractures you should be finding. It doesn't mean that when you get to 5 times the number of hip fractures you stop finding patients, but most FLSs will be way below that, and it's a target to aim for. Serge, you have a question for me here.
Yeah, well, yes, indeed, because so if, say, an FLS, and it's often the case in the beginning, captures only hip fractures to start, okay? And you see that the denominator is times 5 the hip fracture load. So even the most performant FLS that captures all hip fracture in a given hospital, if it captures no other fractures, it would be 20% at best for the first KPI. Is that a bad result? I mean, what does it say to a given FLS?
I think that's a really important point. We are here about developing FLSs. Clearly, having an FLS that finds hip fractures is way better than not having any FLS at all. And indeed, getting a bronze star on the map is a fantastic achievement because it shows you're starting the journey to getting more and more patients identified. But it'd be like me saying to you, Serge, okay, we're in the coronary care unit. We're only going to admit anterior MIs. MIs are inferior or lateral or posterior. We're not going to admit. We're only going to admit anterior ones, which would be ridiculous. But actually, we do that all the time. We say, depending on which bone you break, you're going to get a different care pathway. And the drugs are agnostic. The drugs will reduce fractures irrespective of the site of primary fracture. For sure, some fractures are more likely to lead to another fracture than others, but these differences are small. So I see a great advantage of having an FLS based on hip fractures, but the expectation is this is the first step in a staged implementation to then capture all the fractures.
Okay, so it's great to understand that this ratio on KPI 1 is also to remind us all that the most efficient FLS should, if possible, capture not just hip fractures but all fragility fractures. I understood
Correct.
that now. Thank you.
So the next KPI is around spine fractures, and these are challenging, and that's because they often come into healthcare systems by non-trauma routes. So you need a different way to identify them. They may be coming in clinically with back pain, you may be picking up through Dexa and VFA, or you may be finding them through having scans for other reasons, what we call opportunistic radiological assessment. And we've recognized that vertebral fractures are very important to find because they're common, they're highly predictive of another fracture, but they're the most difficult to find. But if you do find them, actually all of the drugs we have so far are amazing at reducing spine fracture rates. So if there's one fracture that does respond extremely well to our current treatments, it's spine fractures, which makes it worthwhile setting up a separate pathway to find them. Now here the denominator is very difficult because we don't know what it is, and we had to propose something that would be implementable within a guideline or a key performance indicator, but we said in our paper that actually we're going to revise this, and so we've agreed as a consensus that as a starting point it will be about 3/4 of your hip fracture rates. That's the minimum you should be looking at for your spine fracture rates.
But Cass, again, as you said, the difficulty is the denominator. So I'll give you an example. In my hospital, we have a vertebral FLS based on a systematic reviews of chest x-rays in the Department of Medicine and others. So the number of prevalent vertebral fractures that we detect after age 50 on those x-rays is actually greater than the number of hip fractures admissions. So we get a ratio better than 1. Is that good, or is it an artifact because the denominator is somewhat arbitrary?
I think that's good. We've said that for radiological based methods for finding vertebral fractures, you should have a higher denominator, maybe 1.5 times the number of hip fracture, because we recognize that's a much more sensitive way to find fractures. But this is all encouraging. If you're hitting those numbers of vertebral fractures, you can then say, for my FLS, finding vertebral fractures is not the real priority to improve. I can move on to another KPI.
Thank you.
Now, the third one is quite a challenging one, and that's because we now recognize that for an FLS to make a difference, you have to get people onto treatment within weeks of the index fracture. The old pathway where they'd be identified and then be a separate pathway for them to be contacted and investigated, if that happens weeks or months down the line, because of something called the imminent fracture risk, which is the understanding that soon after the first fracture, there is a spike in refractures. We need to get people on treatment quickly. And so we've agreed that the time to starting assessment should be no more than 12 weeks after the index fracture. And in some patients, we're really pushing hard. We're saying for these extremely high-risk patients, as part of their fracture treatment, they see the orthopedic surgeon and then they get on treatment. So we're drifting here towards a much more rapid initiation, but we've set the third KPI to be less than 12 weeks, just to get people thinking more about that imminent fracture risk and the need to get people assessed and then onto treatment as quickly as possible.
Cass, when you say assessed within 10 weeks, you mean interviewed, visited by the FLS specialist, leader, or you mean a full assessment like Dexa scan and prescription, everything?
That's a really good point. I think at this point, because FLSs are all very different, we've just start the assessment by 12 weeks as a rough guide, because you can measure that. You can measure when did you first start seeing the treatment patient, when did the last blood test come in. I'm sure Serge has a huge panel of bone turnover markers that in my hospital takes 3 months to come back. I'm not going to wait for that, but it's when it starts. But the Dexa is a good point. These are global indicators, and we recognize around the world Dexa is not integral to osteoporosis care, mainly through lack of availability and cost. And we have now moved on with tools such as FRAX and other risk assessment tools like Garvin, that we don't need Dexa as a necessary step for assessment. But where you do Dexa, the same rule applies. You need to have the Dexa done by 12 weeks of initial fracture. And this gets over the people who are sort of have a tick box saying bone assessment started, but then wait months for a Dexa scan. And that sort of spoils the whole point of the mission, which is to get people on treatment as quickly as possible.
But yeah, again, Cass, I mean, so in many places around the world, and maybe among our audience, Dexa may not be available or may not be available at all, or not, at least not in the hospital. So we'll take more time to refer the patient. So this criteria judges more of the Dexa availability than the FLS effectiveness, isn't it?
Yes, it does. And I think, you know, in the ideal world, you'd put the Dexa scanner in the trauma unit next to the plaster room, and so you could Dex them as soon as possible. But we recognize that this is a part of the assessment, and you know, there are some guidelines now coming out that you can start and diagnose osteoporosis without a Dexa based on, say, age and the type of sentinel fracture.
So you could score 0 there and still have a good FLS, right?
Completely. It's just that if you do have a Dexa, then you need to be making sure it's not slowing you down.
Okay.
Now, of course, preventing fractures is multidisciplinary, and we're very much focused on the drug treatments, but we mustn't forget the falls assessment. And we've been very active here to make sure we start measuring falls assessment and falls interventions within this key performance indicator, because it's part of a holistic approach to patients. And I think this should be offered to all patients. Some people have said, well, why are you offering it to 50-year-olds, or why not just keep it to over 75 or over 65? But actually, if you've got a 50-year-old who's falling over a lot, that's still a problem. So that's why the denominator here is all submitted patients.
But Cass, again, the falls assessment is a very generic term. I mean, it can go from simple questionnaires of falling risk up to very complex instrumental evaluation of gait, balance, speed, and everything. So what is the minimal falls assessment plan? Yeah,
and that's a good point. And you know, there are tools like FRAT or an assessment of previous falls or the history of the falls, and we haven't been able to get consensus across the falls community, where in the FLS setting, where you may have 20 minutes for the entire assessment, what is a good falls assessment. And so we've left it to whatever is standard for your local, regional, national recommendation. It's because there are some things we can't fix in this first version, but it'd be a great step forward if maybe in the next iteration, in a few years' time, we can actually answer your question and say, this is a minimum standard for assessment for falls in the FLS setting.
So, but I mean, at this stage, you and for all the people attending this webinar, even a simple questionnaire on falls risk assessment would be sufficient.
Yes, for sure. Actually, it's not, the falls risk questionnaires are slightly falling out of favor. What's more important is, why did they fall? And was it due to a cardiac reason, neuropathy, or was it due to a strength and balance issue that needs training and treatment?
So it's an incentive to develop falls assessment pathways further.
Exactly. Don't forget about falls in your effort. We will be measuring this as part of the KPI set, so you will be scored on this.
Thank you.
So the next one is how many people are actually going to get on treatment. At the end of the day, for an FLS to work, you've got to have a large number of patients who actually start treatments that reduce fracture risk. And so we've a very simple measure, how many are recommended osteoporosis medication, and we divide that by all submitted patients. Now, we recognize that calcium vitamin D is really important It's very important to make sure patients are replete, as it reduces toxicity from some therapies. But we also recognize that by themselves, calcium vitamin D therapy is not enough to reduce fracture risk in this very high risk frail setting.
But Cass, what is the optimal ratio here? Because from our own experience in every FLS, for some patients we conclude that treatment is not recommended for a variety of reasons, and those are not accounted for in this ratio that you've shown to us that takes into account only the number of patients that have received treatment prescription. But the opposite decision of no treatment for some patient may be equally appropriate. So obviously it's impossible to get to 100% here. So maybe 50%. I mean, what would be right here?
Yeah, so we've gone for a recommendation rate, just as you said, of around 50%. The reason we haven't gone for a treatment recommendation being made, so we've gone for you've actually recommended treatment, is that we've done some preliminary audit work in the UK, and it's not unsurprising, but your treatment rates between FLSs can vary by between 80% to 20%. Some people are very conservative treating osteoporosis, and some people are very aggressive treating osteoporosis. And so if we just had a marker that said, how many people did you have had a treatment recommendation, then actually we would lose that, and actually many patients would be missing out on treatment. So it's very specific. Of all the people your FLS saw, how many did you recommend an anti-osteoporosis medication? And it could be they could continue the one they're already on, or it could be you're starting a new one. We just want to know at the end of the FLS pathway, how many people did you say, yep, that man or that woman, they need to start treatment?
But how, okay, we can move on. But I guess a related question is to know then, or recognize that this KPI, this percentage, can be very different from one FLS to another, depending on which kind of fracture you preferentially capture.
For sure. And so we actually talk about a little of this in the paper, that, you know, if your FLS is set up to solve the problem of secondary fractures, you need to be making sure that your mix of patients your FLS is seeing includes high and medium risk patients. If you're just seeing patients age 50 with ankle fractures or wrist fractures, actually you're letting all of those high risk hip fractures slip through, then your treatment rate will be low, and this will be a flag to you, to your FLS, to say, why are we not treating many patients? Maybe our identification strategy isn't right, and we're not identifying enough high-risk patients. So they sort of work together to push the FLS to be more efficient and effective by just taking out the really medium and high-risk patients as a priority for your FLS to see.
Thank you.
Now, Serge mentioned earlier the real importance of monitoring. In the old days, when, you know, Alistair McClellan and Stephen Gallagher first started FLSs in the late 90s, it was really a fire and forget, one-stop clinic, get them in, get them started on treatment. And we've done some work now and shown that FLSs that don't have monitoring really struggle to show an effect, if any effect at all. And we know the treatments are low adherence here. So we've made a specific KPI here that at least within 16 weeks of fracture, have you been able to follow up the patient within that time? And that's a really key part of the FLS's job, to make sure any recommendations that are made are then followed through, so the patient gets on the right treatment at the right time.
And Cass, what do you recommend for this monitoring? A phone call to the patient, to the pharmacy, to the doctor, all of the above, because it may be quickly time consuming.
Yeah, and I think that's a really key question. The key things that you want to cover with the monitoring: have they started treatment? Are there any issues that might need a treatment switch? Are they taking their calcium vitamin D supplements? Have they had another fracture? Have their fracture risk changed? Maybe they're eligible for more potent treatments. Are they still falling over? Do they need more falls assessment? And that can be done remotely. And I think, you know, one of the consequences of the pandemic is that we've moved everything remote. and face-to-face clinics are less happening. But it's also shown us that actually the need to do bone turnover markers regularly, Dexa scanning regularly, that's all very good, but actually the primary question is, did you start the treatment and are you taking it properly? Clearly, if you've given a long-acting, sorry.
No, please, go ahead.
Clearly, if you've given a long-acting agent like zoledronate, you know, you don't need to monitor to make sure they're still on the treatment because it's still working, or even denosumab, they've had the first injection because it's a 6-monthly or an annual injection. But still worth getting in touch with that patient to see what their reaction was, did they have any side effects, and the supplements and the bone and falls risk, because that might influence if they come back for the next dose. And really, you should see this early monitoring visit as a way to helping you get as many patients on treatment at 1 year. I don't really mind if this KPI, you know, you don't normally put on treatment. The real aim of this monitoring visit is to make sure that you follow through on the recommendations and you optimize the chances for people to stay on treatment at 1 year.
Thank you. I just want to emphasize something important. You said so monitoring after within 16 weeks does not mean to necessarily recall the patient for a follow-up visit, which would burden the caseloads of many FLSs. A remote call or even card questionnaire could be sufficient. I think that's important for the efficiency of the FLSs that already have a large workload, right?
Yeah, completely. And, you know, we're going to new technologies. I mean, you could put this up in an app, you could do it by email, you could, you know, there's lots of different ways. And, you know, patient societies and patient groups may have an important role here as well. So, yeah, we have to be way more imaginative.
Okay.
So, once you've done your 6-week assessment, within 16-week assessment, the next thing is to make sure they're on the recommendations. So the first recommendation is that you know, there is evidence now that a structured strength and balance class, if properly administered, reduces falls risk and fracture risk. So I think, you know, this is really making sure that you're working with your fall service, and if they have been sent to some sort of exercise pathway, they've at least started it. The main problem is getting people to start and then getting people to stay on. But this is really a sort of a point to the FLS to remember. Don't forget about falls and falls interventions. There are other falls interventions like medication review, footwear review, home hazards review, eyesight review. But we thought strength and balance would be a good marker. And if you're doing good on strength and balance, you'll probably be doing good on these other aspects of falls intervention. The 9th KPI is the most important one. Did they start the treatment? So we haven't gone for the date that they actually started the treatment, because that's actually quite hard to do. You have to ring up the patient and say, have you started yet? Does that mean they picked up the script or had the first tablet? It gets confusing. So a simple rule: what proportion of people have started treatment within 16 weeks of their fracture? And that's amongst all the people who are recommended anti-osteoporosis therapy. And you know, that will probably come down. In some services that may be days, not weeks. And that will be the aim. And you know, we're getting better now at analyzing FLSs and saying, well, if you start everyone at 16 weeks versus 2 weeks, these are the number of fractures you miss. And, you know, and as that evidence builds, it will bring this number further down.
But Kaz, there is quite some experience now and a number of studies, including our own, that clearly show that when you do not initiate therapy within the initial fracture episode, when you refer recommendation to the GP, actually the compliance with the treatment, the starting is very low. So why evaluate at 16 weeks rather than recommend just to make sure you start therapy before discharge?
Yeah, I think that's a good point. And that's where we're heading towards: integration of the FLS with the orthopedic or the fracture care pathways that you have in your institutions. But globally, sometimes that happens within an institution, sometimes because of reimbursement reasons or long-term care actually has to be handled within a community setting. So we kept it as flexible as possible. It doesn't punish you if you start within a week of discharge. That's great, you go for it. But what it does do, it does recognize the inclusivity of different healthcare systems, because in some healthcare systems, you can't put people on a community drug within the acute setting because of the way the reimbursement works. So that's why it was a practical reason. But Serge, if you can do that, go for it. I'm not going to stand in your way.
We do that by experience.
Well, we'll measure it and we'll see how close you are to your expectations. Okay, so the final one is the penultimate one is the 1-year check, and you know, this is probably the most challenging one because it's a year since their fracture. People could have moved, they could have died, lots of different barriers. But actually, at the end of the day, if they're not on treatment for at least a year, you're not going to get the benefit from therapy. So all of the other KPIs have been put in place to optimize your chances of scoring well here. And again, as we mentioned with the 16-week, we don't really mind how the assessment is done, but it just that it measures the key aspects of initiation of therapy. And then the final one is data. It's a bit boring, but actually it's really important. The KPIs are data-driven, and you know, if you don't have the data quality, then you can't really measure how well your FLS is working. And we've made all the KPIs actually record data that your FLS should be recording anyway. So site of fracture, date of fracture, did you start assessment, did they have a Dexa, did you recommend treatment, and did you follow them up? These are clinical questions that will then be lifted off to measure how well your FLS is working and guide you to quality improvement. So we've gone for how many KPIs do you have 80% complete data in without missing data. Now, as Serge mentioned, nothing is 100%, and you know, so we haven't gone bronze, silver, or gold for a very special reason. From all the health economic modeling we've seen, you need to be hitting 80% if you want to be cost saving. You know, it's not about for sure being 50% is better than being 0. But if you've gone to your healthcare minister saying, I want to be cost saving, I want to be cutting edge, I want to reduce secondary fractures by as much as possible, then you need to be getting towards 80%. And you won't get there within a month, maybe not even a year. But if you're on the right trajectory, you'll get there eventually.
Well, Cass, you already answered my question in a sense.
Sorry,
but,
I should have left it. Yeah.
No, it's fine, but I want to re-emphasize this. So I have no FLS. Of course, my effectiveness is 0%. If I just start an FLS and I'm not very good, I may have 30% of the KPIs goals achieved. It's better than nothing, but yet, as you said, it's not good enough to be cost saving, right? That's the point.
Yeah, and you know, my example of the anterior MI versus the inferior and the posterior MI, you know, you want to finish the job. The secondary fracture preventions are really dangerous for patients. They're really expensive for healthcare systems, and they're expensive for the economy when you take into account carer costs, family costs. So you just want to go to your institution and say, I'm going to optimize and do as much as I can to reduce that second fracture or the next fracture. But I agree with you. If I could have every FLS, every hospital having an FLS at 30%, that would be fantastic. But on the trajectory to 80%.
Okay.
So many FLSs, when we set it, just the experience we've had in our local and national work in the UK, the many FLSs said, why do we need to audit? You're adding extra work for us, so we will see fewer patients. And that's a really important concept. You know, everyone has to work within us. We only have a certain number of hours of work. So we're going to be working to this. Why is it worthwhile? And what we've done, some preliminary work, if all of the FLSs in the UK were as good as the best FLS, we would save an additional £151 million just from the hip fractures. And this just shows you how far the spread is in the delivery of FLS within a country. You'll have good FLSs, better FLSs, and FLSs that are green. And if you can just shift them up, the reward is enormous because hip fractures are just so dangerous. And then you can do cool things like this. You can draw a map of your country. You can color all the hospitals that have hip fracture services, or trauma services. And then if they have an FLS, you color them. And if they're great for identification, you color them green. If they're getting there, they're yellow. And if they're less than 50%, you color them in red. And this is a really powerful visual because it just sets your mentors or your key opinion leaders in the country ready for how FLSs will roll out. But the data is only as good as what you're going to do with it. So you've got the data, and you must. The next step is to use the data to identify the priorities, develop your improvement plan, deploy your improvement plan, and remeasure. And it's this continual quality improvement that we now think is the only way you're going to get from get to green in these KPIs. And I'm just going to share an example. So this is falls from the UK data from the service in Oxford, and the pale pink line is the national average, and the dark purple line is our service. And I'm really grateful for the nurses who've done all the work in Oxfordshire for this. And you can see the different PDSA cycles. We weren't very good. PDSA 2, we got better, and we got to 100%. We had some new nurses, and we forgot to include falls in their induction well enough, and our performance dipped. And we quickly reversed that, and now we're up to 100%. And you could never tell that unless you were measuring it. I never would have found out that those new nurses were missing out on the falls. And this is just the power of the KPIs. So what do you need to do next? In the paper that we published, we've included a table. It's pretty small to see here, but it's got all the KPIs, and then it's got all the data you need to record in your local FLS database to be able to generate the KPIs. So many FLSs are starting out, or they're established, and they're thinking, what type of data do I need to record? At least record this data, because this data is going to be really key to getting those indicators set up, and then you're getting better and better. I know the time only got a few minutes left. I just want to make an important announcement. I don't know if you were on Twitter yesterday, Serge, but was it 2 days? 2 days ago, we had a really important launch of a capital fracture partnership, which is led by the IOF. And this is the response from Philippe Halbou, and this is a global initiative to really drive FLSs, and we'll use the KPIs as a key ingredient. And what will we do differently? Well, we've set up 5 pillars of activity, from policy, coalition, mentorship, scalable solutions, and digital tools, and these will develop resources that can then be used by FLSs across the world. We've got our priority list of countries to go to, but even if you're not a priority country, these tools will be available for you to adapt and implement locally in your healthcare system. So to summarize, I hope we've been able to explain to you the reason why we need KPIs. We spent a lot of time on how they work, and the next step is really align your databases and data collection tools to the KPIs and start your quality improvement journey. Get trained up if you don't know about quality improvement. There's lots of free resources on the internet, and we'll be developing some within our mentorship program at the partnership on quality improvement. But we think by doing that, you'll really help your FLSs get to green. So,
well, Cass, fantastic. Thank you very much. And we now have about 15 minutes to answer the questions from the audience that we are receiving. So maybe I'll ask you the first one we got, which is, I think there still seems to be some confusion about the difference between the best practice framework questionnaire and the KPIs. Could you once again clarify in which setting and at which time one should use one, the other, or both?
Yeah, that's a really important point. So I like cooking. So I see the best practice framework as making sure you've got the right ingredients. You've got enough food to make the meal. And that's really important. So if you're missing out on identification, the best practice framework will show you that. The KPIs is actually looking at the food you're cooking. Are you cooking it the right way? And that's at the just making sure you've got the right way, and it's actually, you say you're doing identification, are actually delivering it on the plate. So I would use both. The BPF will tell you to make sure that your organization is right. You've got the right ingredients for the FLS, and the KPIs is how you use those ingredients to make your KPIs effective, efficient, and delivering a good patient experience as possible.
So would you say that it doesn't make much sense to use the KPIs if you have not undergone through the best practice framework already?
Yeah, I agree. If your FLS hasn't got the right ingredients, so you're not doing any monitoring or you're not finding all your patients, then you need to get that set up, making sure you're set up. But I think the KPIs are useful when you're planning your FLS. If you know what you're going to have to hit, that'd be useful. And in those new FLSs who are maybe doing just hip fractures, then it's still very useful. So you could make sure on those hip fractures you've got the right performance. So I don't tend to see it as an either or. I would encourage people to do it both, but start with the BPF framework first. That will get your ingredients ready, and then the KPIs will just make sure you're cooking it in the right way.
Cass, another important question relates back to the KPI 1 and 2, the percentage of vertebral and non-vertebral fracture that are actually captured in the with respect to the burden of all fractures in the hospital. The question is about the denominator. Is the denominator the fragility fractures, or should it be all fractures? I think that question is extremely pertinent. That would include all traumatic fractures as well, because we've seen the recent by B. Leslie and the tour by Steve Cummings in the JBMR that shows that there is actually no difference in fracture rates among people with traumatic and non-traumatic fractures. So the denominator, is it all the fractures that come in my trauma center, or is it only the fragility one, or the so-called fragility ones?
Yeah, I think, and
it's I think that one, I know.
It's a tough, and I think it just reflects the evolution of the science and how we're moving on. I think given the status of FLSs around the world, I think it'll be safe just to focus on the fragility fractures and get them sorted and out of the way. And then if you want to go to traumatic fractures, you can. Most FLSs, from my experience, are completely overwhelmed and they're under-resourced for their fracture volume. If you have enough volume, then for sure bring in the traumatic fractures. I have no doubt a 75-year-old who breaks a bone after major trauma is going to have osteoporosis at a very high rate. And we've seen papers showing the drugs even prevent traumatic fractures, as you just said.
Another question is about the time for assessment. You set up the standard at 16 weeks. Someone mentions that, yes, indeed, many patients, particularly after hip fracture, are in pain and are disabilitated for quite some time. So the assessment can be delayed. I think that's the reason why you proposed the 16 weeks, actually, right?
Yeah, but I think we want to get people on treatment quickly, and actually to assess them can be done over the telephone. You don't need to examine them and move them around to assess their fracture risk. You might need a blood test to make sure they're not in renal failure, have a low calcium. But if they've got a normal calcium and a normal renal function, and you're going to supplement them with calcium and vitamin D, and they're at high risk, you're good to go. And that shouldn't be delayed by recovery. This is changing the mindset. We've got agents coming on that are very fast acting. We've already got agents, the parenterals, that are very fast acting, and we will lose fractures if we wait too long, because the drugs do take a while to work, especially the orals.
Well, that almost answers the next question, which I will answer personally. Someone asking if IV zoledronate can be initiated prior to discharge admission. The answer is definitely yes, and then you will make sure that that particular patient contributes 100% to your monitoring at 16 weeks, because he will be treated. So I guess you agree with me, Cass. Better sooner than never.
Yeah. Do you want to comment on the 2-week rule, Serge? Because that's a lot of confusion in the community about that.
Yeah, well, I mean, the 2 weeks rule for administering ZOL is derived from a very small set of data, very small subgroup from the initial ZOL trial post-hip fracture. It has to be taken with caution. We don't believe there is actually a reason why ZOL should not work if administered even at the time of surgery. At least that's what experimental data would suggest. So I would not rely on these 2 weeks or 6 weeks rules too much, because again, then the risk is the patient never gets treated, and better earlier than never.
Brilliant. Thank you, Serge.
Okay, so someone here is already complaining, Cass, because he says we know percentage will vary according to the type of institution and healthcare system. So in if that person says healthcare system is an open one, no captive patients, then you will hardly get to 80%. Would you comment on that?
Yeah, I mean, I suppose it goes back to what you've been funded to do. So if you've been given the job to deliver an FLS that's going to reduce refractures as much as possible, you need to have a system that's big enough. And you know, I've worked with people in really open healthcare systems where the Dexa is in one hospital, the trauma unit's in another hospital, and the FLS is in another hospital. And some systems are community-based. You've got like 20 primary care centers to coordinate. So I think the method of how you get to the KPIs will be locally determined, but your outcome's the same. You want to get 80% of your patients at risk identified, and you want to get as many of them on treatment as possible. I don't really mind how you do it, and maybe the standard classical FLS model with a nurse and a coordinator going to trauma outpatients works in some settings. I think we're seeing with the pandemic, it's not going to be the model of the future, and we're going to have to be a lot smarter, virtual clinics, virtual assessments, and remote monitoring.
Okay, well, thank you.
So
we
they're
have
going to
another
stay annoyed.
comment or question on the 52 weeks mark. And the remark is that we all know that adherence drops another level in the second year. So why not set up a 2 years assessment mark for adherence? Why set just 1 year?
Yeah, that's a great point. And I would strongly encourage you, if you can do that, do that. But at the moment, these are incremental performance indicators, and nearly every FLS in the world will struggle to get the 1 year data. So we didn't want to put too much pressure on the system. And to be honest, if you got people stable on treatment at 1 year in an FLS setting, rather than using big data where it's primary care derived treatment, I think in the FLS setting, if they've had that communication with the FLS, they've had a monitoring visit at 1 year, I would be surprised if there's that much fall off in treatment. They've been monitored twice. The WU systematic review clearly showed that adherence rates are better in the FLS setting. And I think if we've got the monitoring in place, they're on treatment at 1 year, that's enough. Otherwise, you'll end up monitoring them for 10 years and your FLS will explode because you'll just replace the healthcare system.
Yes, absolutely. I think we need to emphasize that the monitoring at 4 months and then 1 year is there to assess the efficiency of the initiation of the procedure by the FLS at the patient level. And further down the line, I think the responsibility to keep the patient on treatment falls slowly out of the responsibility of the FLS, but goes back to the treating physician. Sure. And that is why we will not evaluate too further down the line. Yeah. Cass, one more question. We go back to the Dexa question, which seems to be a problem for many because again of the availability, but not only about that. Some people are using different devices than Dexa, even at the bedside, and we know now of some portable ultrasounds that seem to have a better performance than the previous ones. There may be other ways to test bone quantity or quality than Dexa becoming available. I would include personally even the abdominal CTs with image recycling that is developing all these methods. So we have not mentioned these methods. So if in my given hospital patients' bone density, strength, whatever is assessed by something else than Dexa, can I use that as a surrogate to score on that particular Dexa KPI, or is it Dexa?
No, I think that's a really good point, and maybe the next revision will make that clearer. It doesn't matter how you assess the bone strength, which modality you use, just make sure it doesn't slow the pathway to getting people on treatment. It was specifically put in there because we know in some healthcare settings, it's slowing down the pathway a lot. And we just wanted to alert people that that's a problem you need to address. And maybe, I think the AI methods for vertebral fracture and also vertebral bone density testing are really maturing rapidly and will be a great aid to FLSs.
Thank you, Cass. Well, I think we've covered the questions from the audience, but before I give back the microphone to Dominique Pierrot. I would like to ask you one more time, Cass, from my own perspective. We now have the best practice framework in place. We'll have the KPIs in place. It's a lot of questions, and it's a lot of self assessment, review, and monitoring. Are you not afraid that we will discourage half of our audience here that does not yet have an FLS, and in the other half that does have an FLS but is not yet on the capture the fracture map from the IOF, discourage them also because the procedure becomes too stringent? So could you re-emphasize the benefits of using those tools?
Yeah, I think it's a really important point, and the theme, the motivation, the aim of this is to make your lives easier. So if you don't have an FLS, you can then look at the best practice framework, you can look at the key KPI indicator set and say, this is what I should be aiming for. And then you can say, well, if I want to deliver this in my healthcare setting, this is what I need. And there are tools we're developing for that. If you've already got an FLS and you're doing really, really well, this is a way to tell other FLSs how well you're doing, and then you can share that experience and get more FLSs set up in your region or in your country. If you're an FLS and you're not sure if you've actually got a problem in one part of the pathway, we've now given you a standard way. We don't need to know what you scored. This is for you to use. You can say, okay, actually, this part of the pathway isn't working well. Because at the end of the day, we all want to do what's best for patients, and we want to make the most effective use of our treatment. And services have to change. I mean, after the pandemic, everything has changed in our region, how trauma works, how orthopedic works. And so without these KPIs in place, we won't be able to check to make sure that we're keeping up with the change and still ensuring that we're delivering on our expectations, that ultimately our healthcare system is investing in us. Our providers are paying us, investing in us to do the job. And this, I think, is a really nice way and a helpful way for FLSs or people setting up an FLS to sit back and say, this is what good looks like, this is how I'm going to get there, and I'm going to have a structured and easy approach. Because I know if I follow these steps, I'm going to get to gold, I'm going to get to green.
I'd like to add from my own experience, that is, we've been running an FLS for 19 years here in Geneva, but it's only when we started to apply those evaluation tools to ourselves that we realized we were spending a lot of energy and resources to do things that were not necessarily effective, because we actually did not have a high percentage of patients on treatment by 6 months. So I think it's also a good way to make sure that whichever resources you have or an FLS has, it uses them in the best possible way.
Perfect. Well, I couldn't have said it better, Serge.
Well, that would be our conclusion, because we're getting to the hour. I'd like to thank the audience, and hand back the microphone to Dominique Pierrot with some important last remarks. Thank you all, and good day or good evening wherever you are. Dominique?
Thank you. Good evening.
Yes. Thank you. I just would like to inform the attendees that we will post the recording of this webinar on the IOF website, and that you will receive the link to the recording by email tomorrow. I also would like to let you know that you will be prompted to fill in a survey immediately after this webinar. We would appreciate your input and comments as we continuously try to deliver webinars that meet your needs. And if you have any question or comments, please do not hesitate to send them over to webinar@iofbonehealth.org. And to conclude, on behalf of IOF, I would like to thank again Professor Kassim Javed and Serge Ferrari for their great and interactive presentation. And I wish everybody a nice day or a nice evening. Goodbye.